Okay.
You're all set.
Good morning, everyone. Thank you for giving me a chance to give you a presentation. It's my honor to give you about a case. And my name is Ma Wenbing, and I came from Binzhou Medical University Hospital and Department of Neurology. First, let me introduce my city and my hospital. This is Shandong province, and my city is located in the north of Shandong province, and it's a beautiful city. And this is my hospital. And my hospital was verified and assessed as a grade 3 and class A hospital, and is the highest rank in China's hospital classification, and since 1995. This picture is all about my department, and in our department, we have over 115 beds and 46 doctors and over 17 nurses, and we are a big family. Now, this is my guideline about the case report. And first is the case characteristics, and the second is auxiliary examination. Third is diagnosis, and next is treatment, literature review, and outlook and the future. First, let's see about the case characteristics. The patient Liu, male, 55 years old. Personal history is no history of trauma, surgery, no history of toxic exposure, no history of smoking, drinking. The patient's chief complaint is involuntary movement for 2 years, aggravated for 4 months. The present medical history is a patient presented with rapid, irregular, and aimless involuntary movements of the lips about 2 years ago, without obvious inducement, no facial and limb twitching, no headache, dizziness, no memory loss, no mental abnormality, no limb twitching and disturbance of the consciousness, no fever. The above symptoms presented progressively aggravation. The right side was more severe than the left side. The patient was not diagnosed and treated symptomatically after onset. Before April, the patient accompanied by facial muscles and the corners of the mouth, uncontrollable twitching symptoms persisted. Look at this is a genetic map. We see the black is sick and the white is normal. The patient and his father and his great-grandfather was sick, and his father is onset after age 16, cognitive impairment after age 17, and a third generation of in-laws have a history of similar illness. The patient's two children are currently healthy. Let's see about the physical examination of the nervous systems. The clear mind, fluent speech, mild decline in memory. Cranial nerve was negative, neck soft. Limb muscle trains level 5, muscle tone normal, tendon reflex normal, Babinski cell negative. No sensory disorders. Chorea can be seen in his head, face, and limbs. Let's about see the video. It's not typically chorea, it's more like rigid movements. Oh. Do you hear my voice?
Yes.
Okay. Well. I'm sorry. I see someone say I can't hear my voice. Okay. The next video. Okay. Based about the present and the examination, we have the location and the qualitative. The location we think about is a basal ganglia striatum, caudate nucleus, or lenticular nucleus. And based on the midnight rules, we think about the disease, maybe genetic disorders, drug-induced disorders, metabolic disease, or structural damage, and other autoimmune disease or infectious disease. But the major we think about is the genetic disorders. Let's see about the genetic disorders. First is the Huntington disease, which is a mutation of HTT gene. Second is detentorable palynuclear atrophy. It's a mutation of atrophy 1 gene and benign hereditary chorea and spinal cerebral ataxia, also the PKD, which all about the disease is autosomal dominant inheritance disease. Next, we think about the chorea, cancer-cytosis, and the Wilson disease, which is the autosomal recessive inheritance disease. Last is Mecklin syndrome. It's X-linked recessive inheritance disease. Next is the auxiliary examination. The patient's blood biochemistry is normal. The thyroid function is normal. HBV, splinters, HIV is negative. Urine and stool routine were not abnormal. CBC and blood smear microscopic examination is normal. Let's see about the MRI. This is a DWI imaging. We see it's clear. And this is the T2 flare image. We see the basal ganglia and the striatum is not damaged, and it's very clear. This is the T1 imaging, and the sector imaging. Next, we give the patient a score about the MMSE. The score is 26, and the patient is junior high school culture, and there was no KF ring. B vitamins was abnormal, and a cancer-cytis is normal on the blood smear. Overall detection, the important is we give the overall detection of the disease associated with chorea. It includes gene screening and fragment analysis. At last, the result is the HTT CAG repeat is 14.3. So we diagnose the patient is Huntington disease, and we give the treatment is coenzyme Q10 for 5 days, and the patient follow up 1 year later based on the telephone. No significant increase in symptoms, no cognitive impairment, and mental disorders and other non-specific symptoms. Let's review about the Huntington disease. Huntington disease was first reported by Dr. George Huntington in 1872 and was later renamed Huntington disease. It is a rare, incurable autosomal dominant inheritance neurodegeneration. The prevalence of the disease was 5 to 7 every 100,000 persons in the white population. The prevalence of the disease was lower in Asia. The prevalence rate was basically the same for men and women. The average age of onset was 14 years, and the survival time was 15 to 20 years. Huntington means HTT is a disease-causing gene. It is caused by abnormal expansion of the CAG trinucleotide repeats in the IT15 gene located in the chromosome 14,4p 16.3 region. Individuals with more than 13.6 CAG repeats may develop this disease. However, if the number of the repetition is 13.6 to 13.9, the total dominance is lower. The number of CAG repeats was unstable, and the number of CAG repeats could be changed when the CAG was inherited to the next generation. The length of CAG repeats is the most important factor to determine the age of onset. The more CAG repeats, the younger the age of onset. Also, we see the clinical feature about the Huntington's disease. It includes dyskinesia. It includes involuntary movement and autonomic dyskinesia, and the cognitive impairment, which means dementia. Also, the patient has the mental disorders like depression or anxiety. And the non-specific symptoms is a disorder of sleep cycle or weight loss. Especially in teenage Huntington's disease, the motor symptoms are severe. Chorea is mild. It also has the dementia or seizures. A diagnosis about the Huntington's disease is no imagination technique alone is sufficient to diagnose Huntington's disease. PET and MRs has also been reported to be helpful in the diagnosis of Huntington's disease, but their clinical value remains limited. According to the typical clinical manifestation, the positive family history basically made the clinical diagnosis. Genetic testing helps confirm the diagnosis. The treatment includes the symptomatic treatment and the etiological treatment. The symptomatic treatment, the first is the tetrabenazine, which is approved by FDA. Also, the antidepressant, antipsychotic drugs, creatine, cognitive behavioral therapy, adaptive therapy, or physical therapy is also needed. Etiological treatment include gene therapy, stem cell implantation, and other indirect that's not possible at this time. Recent years, many papers about the Huntington's disease is published in high-indexed literature, which includes PNAS and also in Cell and Nature. Also, some gene and new drug therapies approved. In 2017, FDA approved a pseudo for the treatment of Huntington's disease. And in 2019, the Uniqure launches gave the AAG gene therapy trial for Huntington's disease, which is also the first FDA approval. We know about the Enroll-HD is the largest prospective observational clinical research platform for HD patients in the world. And in China, we have the CHDN and the Charitable Organization for Huntington's disease. We think all about this measurement maybe give the Huntington's disease patient a bright future. And as the last, we know our learning is about to end in the next week. And to be here, my colleague, Dr. Chen Chao, and I, we are very thanks for Dr. Bernard, Dr. Stan, Dr. Naka, and your team to give us so many techniques and experiments, and also give us so many different patients, different types of patients. We learn a lot. And that's all. Thank you.
Thank you very much.